Thank you very much. We can start this interesting interview with Professor Scardino about his outstanding career. And the interview will be conducted by Dr. Rafaela Malinaric, a resident of mine. Please, Rafaela.
Dear Dr. Scardino, thank you for taking time to meet with us today. To start, I'm curious, we are both curious. Have you always felt a natural urge to become a surgeon and urologist? Or was there a standout moment in time that made you pursue this career?
Well, Rafaela, it's a pleasure to be with you and Professor Terrone today, and welcome, greetings to the Italian Urological Society.
Thank you.
So my career was influenced very much so by my father. He was a urologist in private practice in Savannah, Georgia. So I grew up exposed to urology and used to make rounds with him in the hospital and go to the operating room sometimes when I was a young man. But really the deciding factor for me was a single, as you call it, standout moment. When I was a senior in medical school, I went to medical school at Duke in North Carolina. I was rotating on urology, and I was assigned to go to the operating room with help with a radical perineal prostatectomy. The chief resident was there in the operating room, and the nurse said to the chief resident, when we had the patient prepped and draped, aren't you going to begin the operation? And he said, I'm not going to start the operation until the attending is here and I know he's in the room. The last time we did that, we got into trouble. So we waited 30 minutes for the attending to arrive, and the attending helped the chief resident through the case. A month later, I rotated to Boston to the Massachusetts General Hospital, where Dr. Donald Skinner was the chief resident. And I went to the operating room to help him do a radical perineal prostatectomy. And we were waiting around and we weren't getting started. And I said, Dr. Skinner, are you waiting for the attending? And he said, no, I'm waiting for the first year resident. I told him he was going to do one of these cases himself from beginning to end before I finished as chief resident. So I said, I'm going into urology and I'm going to the Massachusetts General Hospital and I'm going to work with Dr. Skinner. So that was a seminal experience for me.
You were a chairman of Department of Surgery, an excellent surgeon, a professor, an author, and a researcher. During your long and remarkable career, it really seems you have done it all. What would you say is your greatest accomplishment?
Well, I thought about that a lot since I had you sent me this question, and certainly I'm very proud to have built two wonderful urology departments at Baylor College of Medicine in Texas and at Memorial Sloan Kettering that had, after I left, as great programs. As chairman of surgery at Memorial Sloan Kettering, we designed and built an outpatient ambulatory operating room for major cancer surgery. It's a 12 operating room freestanding building where we do radical prostatectomies, radical hysterectomies, radical nephrectomies, radical mastectomies. And it's been in operation for 6 years now, and it's been highly successful, a way of doing safe, efficient, effective major cancer surgery in the outpatient setting. But in my own field of urologic oncology, I'm very proud of the work we did with radical prostatectomy, showing that it was highly effective in controlling intermediate and high-risk cancers. In our large series here, surgery alone with no radiation, no hormones, resulted in an 80% 15-year freedom from PSA recurrence for intermediate risk cancers and 50% freedom from PSA recurrence in high-risk cancers. And I think this helped to establish surgery as a single modality effective for high-risk and intermediate-risk cancers. But the most important thing I think that will make a difference in the field is that when I began my training, it was common for surgeons to feel that if your results were better than mine, it's because you cherry picked the best, most favorable patients to operate on, and I operated on everyone who came in. And so your results seem to be better, but really we're very much the same. But we did a study of a large number of patients and operated on by a group of 75 surgeons from 4 institutions, and showed that there was a learning curve, that the surgeons, as they started, had a recurrent cancer for the average patient of about 22%. But by the time they had done 250 operations, that was reduced to 11%. It was cut in half for the recurrence rate, just because the surgeon was now more experienced and knew better how to do the operation. And we continued to study that and found considerable variation in outcomes among surgeons, regardless of their experience, the number of cases, the years they've been working. There was still an unexplained variable that I think is just like golf. There's some people are gifted at the game and others are not. And I think this allowed us to focus on surgical technique as a way to improve patient care and improve outcomes. That it's not all the same. And I hope that will lead to many more improvements in surgical technique in the future.
Mm.
Thank you. Michael Curtiz, famous American actor and producer, once said, "The only things you regret are the things you don't do." Is there something you wanted to do but never did, and now you regret it?
Well, this gets into the personal realm now, because the main thing I regret as I look back over my career was that I was so devoted to my work and my career, I didn't give my family the attention that it deserved. So if I had it to do over again, I'd spend more time with my children and grandchildren. And that's what I'm doing that now that I'm in this phase of life where I've finished my surgical career and I'm spending more time with children and grandchildren. So I could have done it much earlier.
Okay.
Great.
When you were a young surgeon, were there moments or periods where you wanted to give up? Tell us about the biggest challenge you've faced and how did you handle it? Where and how did you find your motivation and drive to continue?
So this reminds me of the time when I was a first-year resident in urology at UCLA in 1976. I had spent 2 years in surgical training and 3 years in research at the National Cancer Institute. And I went to UCLA, and as a first-year urology resident, I was very disappointed that I wasn't doing more surgery, that I wasn't engaged in important research like I had been at National Cancer Institute. And I remember I said to my best friend, I came 3,000 miles for this residency program, and it was the worst decision I've ever made. Naturally, I stuck with it. I had some trouble that first year. I had a patient who I was assigned to do a transperineal needle biopsy of the prostate on, and I wasn't familiar with the particular setup they used, and so I drew this clear liquid up and to anesthetize, thinking the liquid was lidocaine, and it was formalin. And so I injected a patient's perineum with formalin. It hurt like crazy. He let me try twice, and it was not getting any better, and I stopped and realized the mistake. But I talked to him and his family, and this was reviewed by the Department of Urology, and they decided not to fire me as a resident. And so I was grateful for that. And as time went on, by the time I finished the program 3 years later, I thought it was absolute heaven. I thought it was the greatest experience I'd had in my whole life. So I stuck with it. I kept doing my job, keeping my head down, and things worked out in the end.
What advice would you give to a young urologist who is at the beginning of his career? What are the most important qualities one should possess to have a promising career, to feel accomplished, and to make a contribution to medical and scientific community?
Not easy.
Well, I think
Not
I deal
easy.
with fellows all the time in residence, and I think that you have to think urology. The essence of urology is doing procedures. No one else, we don't compete with the nephrologists for doing procedures like the cardiologists do with the interventional radiologist and the general surgeons do with the gastroenterologist. And the most important thing you can do is learn how to be a very good surgeon. That's ultimately what you're going to be hired for. That's what you're going to be paid for. And you can be a brilliant researcher and do a lot of interesting papers, but if you can't take good care of patients and perform a high quality operation, you're going to eventually run into trouble with your career as a urologist. And the great leaders in urology I've known have been very good surgeons. And I would say that's the first goal, is to stick with and pay attention to your surgical training and be sure you get adequate surgical training. I think the second big decision young doctors make is, should I go into academic medicine or should I go into practice? And I think that my father was in practice and found it deeply satisfying, great respect for practice. I went into academics because I wanted to be able to have the resources to ask questions and get answers if I had reasonable questions. And that's very hard to do in practice. You've got so many business responsibilities, but in an academic medical center, you're free of many of those, and you can pursue research questions and consequently teaching. So if you love teaching and love research, then academics is the way to go. But if you're not excited about being able to ask questions, if you want to get on about your business, then practice is a perfectly reasonable alternative. And many doctors in practice have made important contributions.
Perfect. And the last question. You once said that a great surgeon understands when and how to incorporate surgery into the total treatment plan for each patient. Nowadays, we are witnessing development of minimally invasive treatment modalities such as HIFU, cryoablation, and targeted therapies, or even prior to that, genomic testing. After decades of being an expert on the prostate cancer in the multidisciplinary setting, what do you think will be the role of surgery in the treatment of prostate cancer in the future?
Yes, well, I lecture about this every year. I give a talk called Prostate Cancer, My Perspective. And it's just very much my opinion about it. But look, I think radical prostatectomy has a lot of advantages. We've talked about some of them. It's highly effective for cancers that are potentially lethal. It provides the pathology that allows you to analyze what's really in the prostate and accurately grade and stage the cancer. It provides tissue for analysis. It reduces the PSA to 0 if the cancer's been completely removed, and the PSA is a very sensitive indicator of recurrence. And early salvage radiotherapy is feasible. It can be done when the PSA begins to go up, and it's effective. So this is a very good treatment, and it'll be around for some time to come. I think the immediate short-term future is bright for radical prostatectomy. I think it will, as we develop better and better biomarkers, circulating DNA, circulating tumor cells to identify tumors more accurately. As imaging improves, PSMA PET scans will be able to identify metastases in some of these patients before surgery, so you can reevaluate whether the surgery is really indicated. I think the ability to use molecular probes to carry a fluorophore right to the cancer and excite it with a laser light so that you can see where the nerves are during the operation. We're studying a nerve illuminating drug, or you can see where the margins of the cancer are and if you've completely resected it, or whether there's cancer in a lymph node. These things will make surgery even better, particularly robotic surgery. And with the more and more available and effective systemic agents, we may find that in the not too distant future, we'll be doing more surgery for people with limited metastases. But at the same time, there's some major threats to radical prostatectomy. And that could make the operation become much less frequent. One is active surveillance, as active surveillance is more widely accepted and expanded to different types of disease. Another is focal therapy. You mentioned HIFU and photodynamic therapy. Focal therapy being worked upon. We don't yet know what its role will be. The use of staging studies like PSMA PET scan, if they're done preoperatively in a high-risk patient and find metastases, then you're not going to be operating on that patient, at least not right away. Radiation therapy is becoming better and better. There's a serious study of single-dose radiation therapy that can give 24 gray in a single dose in a 2-hour session, and you're done. You've been radiated, and the results are looking very good, and that could compete with surgery. And as better and better drugs come down the pipeline, some of them may prove effective for getting rid of local tumors. So I think there's a possibility that surgery could 10 or 15, 20 years from now be much less common. But you don't know. When I was chief resident, when I was first year resident at UCLA, the chief resident sent me to the operating room to help the chief of surgery with a radical prostatectomy. I said, "Why are you letting me do this? I'm just a first year resident." He said, "Well, you need to see this operation because it will soon be replaced by radiation therapy and nobody will be doing them anymore."
About your lectures, prostate cancer, my perspective, are they posted online? Can we find them somehow?
Yeah, I have a set of slides that I use if that's what if that would do it. I don't have the text that I give along with it. But if you'd like the slides, I'd be happy to send them to you, Rafaela.
Yeah, thank you. Thank you very much.
So we have to continue to teach and to learn radical prostatectomy.
I think so. I think we should be teaching it, expecting it to play a major role for some time to come.
Only minimally-invasive or also open?
Well, I think that, as I'm sure you agree, minimally invasive, or I call it minimal access surgery, robotic surgery for the prostate, has given us a remarkable tool to do the operation with less blood loss and quicker discharge from the hospital. But it hasn't really improved substantially the chances of curing the cancer, recovering erectile function or urinary function. So it's been disappointing in some ways, but I think as we develop things like intraoperative imaging, the ability to label the cancer in the nerves and the bladder edge, it'll help us really improve the surgical margins, get more complete resections, avoid damage to normal tissue. And I think that can be done much better with robotic than with open surgery. I think open surgery has achieved what it can. I certainly thought I kept doing it all my career, and I was happy with the results up to the last minute. But I think the future belongs to robotics, and particularly if it can be made less expensive, it would be more available around the world. But I think that's what's going to be in the future. And some of the things that are improving can be much better done with robotics.
So thank you. More than 20 years ago, I was in New York in your department, and I learned from you the nerve-sparing radical prostatectomy. It was beautiful. Thank you very much again.
Well, I'm glad to hear it was a positive experience.
So yes.
That was the early part of this millennium.
Yes.
Wonderful.
Scardino, can I ask you the last question?
Sure.
Do you have any Italian roots, maybe?
Yes, I do. And my great grandfather came from Sicily with his brothers when they were teenagers. They got on a boat in Sicily and ended up in Galveston, Texas, in the 1880s. And the three brothers came after they settled. They sent back to Sicily for wives, and the women came over and they got married and had big families, and are spread out all over southeast Texas in the Houston, Beaumont area. And my father was the first one, the third one in America, but the first one to marry a non-Italian. So I'm half German and Irish and half Italian. But my children are very interested in Italy. My daughter teaches Italian history in university here, and every summer comes to Siena and has a 6-week course for American students to learn about Italy and the culture and the language. And my granddaughter is now majoring in Italian and neuroscience at Colgate University. So yes, a lot of interest in
yes,
Italy.
yes.
Have you ever been to Italy?
Many times. One of the first times I went there was with Michele Pavoni Macaluso.
Yes,
I don't know,
in Palermo.
Palermo. He had the
Yes.
wonderful meetings in Erice.
Yeah, it's wonderful, yes.
And I came to probably 4 or 5 years from beginning when I was a resident. So
okay.
And we've been there for vacations and to visit friends, and it's a wonderful country. I love it.
So we are waiting for you here in Genova.
Yes.
When the pandemic's really over, we'll do a lot more traveling again.
Yes. I hope.
So how is it in Italy now with the COVID pandemic? Are many people vaccinated?
Yes. About 25% of Italians received the vaccine. Yes.
So the case numbers are starting to go down.
Yes.
Right.
Okay. It's better and better, the situation.
And the States?
Yes, it's really been remarkable. They're opening up in the States much more quickly than I thought they would. We had only we had 100 deaths yesterday, so the death has dropped from 3,500 a day down to 100, and the number of new cases continues to drop dramatically. So instead of many thousands a day, it's in the hundreds. So it's improved quite a bit, and now you don't have to wear a mask on the street when you're walking. The restaurants are now fully open.
Okay.
And
no, in Italy we start only now to have a open restaurant and the possibility to go without mask outside.
It's been interesting in New York, all the restaurants, if they can't sitting area on the sidewalk or in the parking spaces on the street, so they have extensions and they could serve food outside. So it's sidewalk cafes are now all over New York.
Yes.
A very European tradition.
Yes, European tradition, yes. So thank you again very much on behalf of our Italian Society of Urology. This interview was wonderful and will be replaced and reproduced during a live surgery meeting organized by our Italian Society at the end of June. And I think it's really a pleasure for us to hear your experience and your impression on your career.
Thank you very much for having me. It's an honor, and give my greetings to all the members of the society.